second and just have a little review of the business of coupled and combined movements. And what are we thinking about here? Let's just come back to the seats here for a second. I hesitate to rub this off, this whole plan of how we look at the thoracic spine. We need to address the problem of the thoracic spine and its motions, or any part of the spine and its motions, because if we use motions which are associated and we have a coupling, if we use these motions therapeutically, it means that we're actually doing a technique that the spine kind of likes to do, but it's not going to sort of force the movement to a particular level. And we may need to do that on occasion if one level is very stiff, let us say. And so when we use coupled movement in terms of how we move, there is a natural propensity for, if we side bend, to rotate in a particular direction. And we can move functionally and happily like that in terms of our daily life. And if we use those kinds of coupled movements, what it gives us is a semi-specific mobilization. In other words, we're trying to mobilize over an area and not to stress it too much. We're trying to encourage it to go in its direction. That's one thing. The other thing that coupling gives us, it gives us the way that we should try and educate functional movement. This is the way the spine likes to move. So let's give the patient the engram of this is the way that I want you to move, of normal movement. Now, having talked about coupling, what is the coupling that goes on in the spine? There has been controversies about this going right the way back to the original work of Lovett at the turn of the century, and then the development of the Halliday spine, which was simply an osseo-ligamentous preparation, which he then forced into a variety of positions. This was taken up then by Fryatt, who produced a number of laws. Of course, they weren't laws in the sense of what scientific laws are. They were kind of like hypotheses. They weren't like laws that we produce when we think about it. I mean, they are true, okay? But they were hypotheses. And we've had a problem with these hypotheses in terms of the reasoning and then what the movement is. Now, let's just go through Fryatt's laws of motion for a second, because we had a little sort of discussion here, and we need to understand these before we can do some of these movements. Now, Fryatt wrote 3 laws. And the first law was related to when side flexion and rotation go in opposite directions. And they were said to follow the type 1 law principle. he wrote, or he expressed the second law as when side flexion and rotation are in the same direction. And the type 3 law, I'll have to paraphrase this, is that if we take up movement in one direction, movement in all the other directions will be more restricted, which is reasonable. I mean, if we've got an amount of capsule that allows movement, and then we take up some of that slack in one direction, and then we try and superimpose another movement on that, there isn't as much slack to go. Equally well, it means that if we've got, like a therapeutic significance of this, that if we have movements that are coupled together and we kind of have one that isn't quite as bad and we try and restore that motion and we get a little bit of success, when we go back to the motion that seemed primarily restricted, it'll probably be a little bit better because we've put tension on the capsule and we've stretched it in that way. So these are sort of points. It's to do with taking up movement and then in a variety of directions. But we're going to be concerned with type 1 and type 2 rules. Now, Fryatt described the reason for the type 2 rules as being when the zygapophyseal joints, the facet joints, are under load. And the load can be because it's in its close pack, or it can relate to it being under ligamentous tension. Now, when would those situations occur in the spine? Flexion and extension, correct. Now we look at when is the spine going in opposite directions. This is from this description when the zygapophyseal joints are not under load. And where will that relate to? It'll relate to the neutral position. Okay, so we look at this and we think to ourselves, right, in all the areas of the spine, when are the zygapophyseal joints under load? And we take the cervical spine. Because of the orientation of the facets in the cervical spine, it's always under load. So regardless of what is the position in terms of flexion, neutral, or extension, the zygapophyseal joints are under load, and so it follows the type 2 rule, that rotation and side flexion will be in the same direction. That seems to fit. Until you ask yourself, okay, if it's under load, how about the joints in the cervical spine that are under the most load? Which are they? Of the craniovertebral. They're exactly like this. Atlas holding the world. And so we have this not quite fitting the rule. Except, of course, he could probably come back and say, ah, yes, but it's only when they're under load and there's a disc there. Because the first two don't have a disc. All right? But it doesn't follow the rule exactly. But from C2 downwards, side flexion, rotation will be in the same direction. Sorry, let me... C2 down, side flexion, rotation in the same direction. And that will go down to probably about T3, where the cervical spine still extends functionally into the upper thoracic. Now, in the lumbar spine and in the thoracic spine, because of the arrangement of the zygapophyseal joints, and according to Fryatt's rule, in flexion and extension, those facets will be under load, either in the close pack or when they go forward and there is tension on the ligaments. And in the neutral position, just in the ordinary neutral upright position, those facets are not under load, so side bend and rotation go in opposite directions. And that's what Fryatt said. But there's been a problem insofar as a lot of the reviews in different parts of the world, apart from in North America and with the osteopathic circle, certainly the Europeans believe that in extension, and this is the only difference from Fryatt's rules, okay, that in extension of the thoracic spine and the lumbar spine, it's thought that side flexion and rotation are in opposite directions. So, in neutral, opposite. In flexion, same. So, all you have to remember if you've learned these Fryatt's laws is that as far as the sort of general out there is concerned, there's perhaps an area of controversy, and it's just what happens in extension of the thoracic and the lumbar spine. Does it go into same or opposite? Perhaps we should sort of experiment a little bit and just see what we feel. And as we're all into feelings and that, we should be coming up with some kind of satisfactory explanation. And of course, at the craniovertebral area, we know it goes opposite. And that's fairly well established, and it's driven opposite by the arrangement of the ligaments, particularly the alar ligament. It has to move that way to keep a constant tension on the alar ligaments. So it's a pretty good stab that Fryatt had. Now you would think by now that we would have sorted out with cine radiography and multiple planar x-rays and all the other things that go on, actually the definitive answer for this, and it just has not been done. You look at Diane Lee's book on the pelvic girdle, which is an excellent book, and she sort of addresses this problem in the sense that she has a little table which shows what happens at L5-S1 according to very prestigious world figures. I mean, we're talking about Piercy, who did a lot of work in Oxford. We're talking about Grotowecki, who worked with Farfan and has produced the Spinex machine and all this in Montreal. They give the two things that happen at the lumbosacral junction are entirely opposite to one another. Grotowecki's theory as opposed to Piercy's theory. We have in Piercy that perhaps what happens is we get an inflection, for example, that we get down to L4-5 and it seems that very little happens. And then we get to L5 and S1 and the opposite happens. So this is one of these things where it just is not absolutely cut and dried, which is unfortunate because it'd be nice for us to know. And another thing that was found by certain workers was that you can actually be producing a flexion of the spine, and we were talking about rotation and side flexion, of course, but if we look at the pure movements, you can go down the spine and you can see they're all flexing one after the other, and you get to one which extends. Now, this could be obviously some degree of instability, that the muscles are bringing this in, so things happen that don't fit all the theories. And I think you should sort of look at this. Now, why I've done this is this, that I'm going to be, for purposes of these things, and it seems to work, to use the European analysis of this, that in extension we've got side bend rotation going in opposite directions in the thoracic spine, apart from 1 to 3. And we've done that anyway, and we can leave that alone, so it's not going to cause a complication. Now, let me just talk a little bit about this. When the spine moves, it moves in a coupled fashion. There's a propensity for it to go with that kind of arrangement. But of course, we can equally well, if we use our muscles and so forth, I can side bend one way and I can rotate in the inappropriate direction if I want to. We have this idea that it's not so good for us, and it perhaps increases the wear if we don't allow it to happen. But many people are forced to do this by the way that they have to work. A machine or something that's set up kind of wrongly. And I suppose quadrant testing is an analysis of doing these kind of inappropriate movements. What do we call these inappropriate movements? It used to be called physiological, which was the coupled movement, and non-physiological movement, which was the when we force away from this. But can it be called non-physiological if we move like this on a fairly regular basis? So we looked at that and had a worry about that. And so that still exists in some of the books. Sometimes it's called coupled movement as opposed to combined movement. And that seems to be the term we're tending to use now. But so we've got coupled movement equals physiological in some of the osteopathic texts. And we've got combined goes with what we used to call non-physiological movement. Now, what's the value of these movements? Well, this is it. That if I have a spine, and let's just take the thoracic spine here, and let's say that I've got my thoracic spine like this, and I go into side flexion over this way. So the spine is coming down into side flexion to the left. This means by the normal combination or the normal coupling of motion that will go on, if it's in neutral, that it will rotate to the right. Would you agree? That's what Friot's first law, which is when the spine is in neutral, would state to us. Now, provided we hold the side flexion that's coming to the left, that means that these bones here will have a resistance to rotation to the left. But we've got to hold the side flexion left for this to occur. So as we go into side flexion left, they go into rotation right. And they're held rotated right so long as we keep the side flexion left. That means that if we were trying to do this as a specific way of moving a level, let's say down here, which we'll make stiff, all right, we would leave this therapeutically in its neutral position. We would use the combined movements down to that point, so that we can make sure that we're going to force the movement to occur at that level. And then we will decide which movement to do. Now let's assume, just because of my description here, that we're going to rotate this bone here between, let's say it's T5 and T6, that we want to rotate T5 and T6 to the left. Now, I don't want any left rotation to occur in any of these bones, because that's going to take away the left rotation that I'm trying to force at this level here. So what I'm going to do is I'm going to place all of those bones in rotation to the right. So I will come down the spine, I will hold these all in rotation to the right and keep them there, and then I'm going to try and force rotation to the left through this rigid lever. It'll be rigid or resist rotation to the left, provided I keep this in side flexion to the left. And that's the whole principle of locking, so-called locking, or localization, if you like that better. Because this can only be a relative term. These are soft tissues that we're building up tension in, capsules and things like that. Now, I think the best thing, instead of me just talking to you about this, is to perhaps try what happens. And I don't want to set you up for any of this at all. I want you to see what happens yourself. And perhaps all this is for the birds, in which case I should go back to Canada. Come and sit over here, ma'am. So this is what I'd like you to do. I'd like you to take a number of movements, all right? And let's say we look in the neutral position here and we ask her to go down into side flexion to the left-hand side. Now, if by the theory it's rotated to the right, what we should be able to do is rotate her to the right, okay, but she should resist rotation to the left. So I want you to sort of come into this. You've got to keep that rotation to the right, to the left, side flexion to the left. It's no good kind of letting her come out of it. So we have to keep that, and perhaps a good thing to work in threes for this, so we can, you know, make sure that we're not losing one of these movements. And now what I could do is see, okay, when I come here, she's still happy enough to go to the right, let me say. How about if I try and push her back to the left? I can feel that it doesn't want to go too much there because that side flexion is holding her right rotated. And when I do this left rotation, so long as I keep the left side flexion, I'm kind of feeling that I can't do that. So if I sort of wanted to, in neutral, mobilize this to the left in left rotation, I could kind of lock her a little bit in that position, and then I could do this, and I would know that the first joint that would allow a left rotation to occur would be the one that isn't side bent or side flexed. That's the principle of locking. Now, what I'd like you to do is this. When we come into extension, of course, it's going to cut down a whole pile of movement because those joints are coming into a close packed position bilaterally anyway. All right? But I'd like you to look at flexion, neutral, and extension. And today, in Portland, we will definitively answer the problem about Freya's laws, because I am in the presence of the birth of giants. All right? So let's do that. See if you can feel anything happening there. Would you do it? And just see if there is a difference. But remember, we're going to be testing rotation, and we'll be holding side flexion because it's easier to do. And then we'll kind of try and get whether if we do rotation, what happens with the side at the moment. And I'm not sort of, we'll put this down on the bed if I can. I'm not saying that you would do these on every patient. Certainly not. If you know what you're going to do from what we've done in sitting, let's get going and treating it. But sometimes you don't feel all that well. So here we are. How can we do flexion, extension, rotation, and so forth in this position here? Well, everything is reasonably easy to do with the exception of side bend. And I would always do side bend in sitting, regardless. So can you put your hands behind your neck? All right. I'm going to take her into this position here, and I'm going to use my thigh on her elbows, like that. My other hand will go round and just hold her wrist. So. Okay, so here she goes. She puts her arms around there. And I can now just come here, and by using my body, I can do a very nice little extension motion. Huh? Just feel. Just by rocking my body. This is a nice way of doing side bend, and of course it's a very good way of trying to restore motion. I mean, it lends itself very nicely to the movement here. And if we've got a pillow that she slide her head on, well, that'd be good too. But some kind of fabric here allows you to slip a little bit, and that's nice, so that that can take place. And we can come right the way down. So just getting more and more into the extended position and not coming back through the whole range like this, because that's all unnecessary effort. All right? Now then, with the flexion, can you just put your hands over here so we don't strain your upper neck? And I'm going to put my hand round here, and I'm going to use my body here on her elbows, which are at the front here, and I'm going to pull her like this now. I'm just going to pull her round like that. Just let her slide on the table. So this is like a forward gliding stretch motion as I come down like that. Okay? Now we'll be reviewing all of this when we do some of the techniques and getting this really smartened up, because the more repetitive we have to do, the sort of better we have to get our grips and things, because we don't want to be stressing them. So the extension, If you want to leave the arms in that, this is the best position for the arms, with the hands around the neck, I think. And you just coming around here, just so you don't keep pushing the neck back, you support the neck with your hand. That's the extension. And the other one with the hands across the front, which takes no time, and that is a very good movement for doing flexion. Now with rotation in side lying, very good. You better remember your earring. So I'll get her into this position here. And I'm going to do 2 or 3 things here. I'm going to try and split the spine best I can into sort of 3 areas, upper, middle and lower, and try and think about the curve here. And just the same way as we pushed with our posterior anterior pressures here, here and here, I'm going to try and work this up a little bit there, more directly backwards, and then a little bit down like this. So I'm going to place her hand. As a male, I kind of am much more aware that we better do this now, so that, you know, you're not kind of working away and you suddenly find you sort of been on a woman's breast for the last 5 minutes. I am a member of the disciplinary committee and I can do without me being hassled by this. Okay, so to place the arm on here has got a number of advantages. A, she's got her hand over the breast, but also it sort of stabilizes the shoulder a little bit, and I can push through here, trying to come through the forearm, and so I feel here and I can do this rotational movement quite well. Coming around here and gradually just changing a little bit the angle. You won't see much change from me, but she'll be able to feel that I'm gradually sort of pushing a little bit more over here and then coming down to the lower part. And with the lower part of the chest, very often I will come over the lower part of the rib cage anyway and just sort of move through here. So I don't have any chance of doing a lot of activity on the posterior part of the shoulder girdle and stressing the shoulder. So I can sort of come back here, going through the rib cage, which is going to be a very good technique for treating mobilization into rotation. Okay, so here we come from the top part here, down a little bit there, through the rib cage there. So let's just practice those, and then after that we'll kind of have a break and then we'll go to lunch. For side bend in side lying, it is such a hassle to kind of lift patients up and all of this thing. I just don't think it's worth doing. Sit them and just see what's happening in sit. But of course, rotation is an expression of what side flexion will do anyway. And therapeutically, you tend to go for rotational corrections rather than side flexion corrections, because it's a little easier to do. Olaf's got techniques over the end of the bed, you know, but I think it's because he likes to exercise all day. So he uses the patients as a weight and then goes and works out in the gym. I was in Mainz in Germany, and we were teaching in the same area, and we've got this huge establishment, I don't know how many millions of square feet, all to do with the training of physical therapists. Just an amazing sort of place. And down in the basement